Everyone. We are going to go ahead and get started. I would like to start with several announcements. The first announcement being, please, just as a reminder, please try to make room in the back for everybody to sit down as much as possible. Squeeze together. There are open seats in the back of the audience. I also ask that we reserve the two side areas for CDC staff and ACIP workgroup members. The second announcement is related to public comment for this afternoon. I just wanted to remind everybody that there are two opportunities for general public comment at the meeting, at the end of the meeting today and at the end of the meeting tomorrow. Excuse me, everyone. Can everyone please be quiet so they can hear me? Thank you. So we've received a considerable number of people who have signed up to make an in-person public comment at the end of today's session. We have many fewer people signed up for tomorrow's session. We want to make sure that we have the opportunity for members of the committee to hear everyone who has taken the time and effort to come to this meeting to make public comment. And so we encourage anybody who signed up for today who will be here tomorrow to consider changing your time to tomorrow. And if you're able to do that, please go to the back of the room and discuss with Stephanie Thomas and Noah Alashir, who are working on that. We want to try to ensure that people who are really only at the meeting today are able to make their public comment today. We also want to make sure that we can hear from as many people as possible. There are some people who have signed up to comment at different times, both during the vote and during the general session. We will go down the list in the order of sign-up, but we do want to prioritize people who have not already had the opportunity to provide in-person comments prior to the meeting. So if you have signed up to speak both days or signed up during multiple sessions, please choose the time that you prefer to speak at, if possible. So after each person who has signed up for comment has had the chance to speak once, people who have already commented will have an opportunity to provide additional public comment, time permitting. We'll plan on having 30 minutes for public comment at the end of the day. As always, keeping your comments to under 3 minutes will be really important to make sure that we have the opportunity to hear everyone who came to make public comment this afternoon. So we really appreciate y'all sticking to that time. I also want to make one more comment now, and then I'll remind you of this as you're leaving. Today is World Polio Day. In honor of that day, CDC is hosting an invitation-only event with the Rotary Club of Atlanta in order to recognize the commitments and progress made towards ending polio. So as you leave the auditorium at the end of the meeting today, we ask that you kindly respect their event as you're departing from the building. I think that means please don't eat their food. Don't crash their party is the underlying message for you. So I'll remind you all before you leave. Okay, so on that note, we can start with the first session. I'd like to call Dr. Hunter, who is the chair of the Adult Immunization Schedule Work Group.
Hello, I'm Paul Hunter. I'm an associate professor of family medicine and community health at the University of Wisconsin and associate medical director of the City of Milwaukee Health Department. As chair of the Adult Schedule Work Group, I'm here to provide context for David Kim's presentation about how proposed changes in the schedule for 2019. On behalf of the work group, I'd like to thank Dr. Laura Riley. She was an ACIP voting member from 2014 to 2018 and chaired the Adult Immunization Work Group from 2016 to 2018. As vice chair of obstetrics and medical director of labor and delivery at Massachusetts General Hospital, she championed immunizations for pregnant women and frequently reminded ACIP colleagues to try to make vaccinations work for busy clinicians. She's even busier herself now with her recent appointments as chair of the departments of obstetrics and gynecology at Weill Cornell Medicine and chief of obstetrics at New York Presbyterian Weill Cornell Medical Center. Get my notes out here. The work group meets monthly to update the immunization schedule each year. Along with the child and adolescent immunization schedule, the adult schedule represents current approved ACIP policy. It's designed to help clinicians implement ACIP recommendations in clinical practice with individual patients. As with other ACIP votes, the schedules are forwarded to the CDC director for approval. In addition, the adult schedule is sent to partner professional medical organizations, the ACIP, AAFP, ACOG, and ACNM for approval. The approved adult immunization schedule is then posted at the ACIP website, and an announcement of its availability is published in the MMWR early in February. The adult immunization schedule is also published in its entirety in the Annals of Internal Medicine in February. Few ACIP updates occurred in the immunization schedule were published since the 2018 schedule was recommended by the ACIP in October 2017. There was the adjuvanted hepatitis B vaccine that was voted on in February and published in the MMWR in April. The Tdap summary was published in April, did not change any recommendations for adults, although there were a few changes for children and adolescents. And as usual, the annual influenza recommendation was voted on in June and published in August. This included the vote from February, bringing back the live attenuated influenza vaccine as an option this season. The addition of homelessness as an indication for hepatitis A that we just voted on will be incorporated into the adult schedule. In contrast, there were several formatting changes that are proposed to increase the usability of the schedule in clinical practice. The 2018 immunization schedule was formally evaluated for usability over the past year and a half. The evaluation process consisted of in-depth interviews of healthcare professionals who reported routinely using the adult immunization schedule. The appearance of the graphics and text of the schedule was redesigned based on these interviews. Feedback on this new design was collected from healthcare professionals by conducting a survey to assess their reactions and preferences. And David Kim will go over those results in his presentation. David will also go over the white spaces issue. In addition to reviewing the results of the usability and interviews in the survey, the work group and CDC subject matter experts reviewed the current no recommendation white spaces in the adult schedule. These white spaces occur for several vaccines in the pregnancy column in Figure 2 of the 2018 adult schedule. This column has been colorfully updated in the draft 2019 adult draft that David Kim will present very soon. Several vaccination recommendations overlap between the adult and the child and adolescent schedules. The adult immunization work group collaborated closely with the child and adolescent immunization work group, subject matter experts, and others to harmonize the language and graphics for these recommendations. I'd like to thank the ex officio members, consultants, and liaison representatives to the work group listed on this slide for their contributions to the 2019 schedule. And I especially want to thank the CDC subject matter experts and support staff who make updating the schedule possible. And I just want to make sure I've got it correct that the questions will be at the end of the child and adolescent. Okay, thank you.
Yes, thank you. So as Dr. Kim is getting ready to start his presentation on the adult schedule, I want to let everybody know that we're going to go through the adult schedule and the child schedule. Because there's been so much harmonization, we felt that this year we could do a single vote at the end. So there will be public comment for the schedules combined, and then a vote at the end of both sessions.
Well, thank you, Dr. Hunter. During this session, I will provide updates in the ACIP recommendations pertinent to the adult schedule. As Dr. Hunter mentioned earlier, the 2019 adult schedule has just a few updates. The reinstated use of LAIV, the addition of homelessness as an indication for hepatitis A vaccination, and the introduction of the new two-dose series of cytosine 5-phosphate guanine adjuvanted hepatitis B vaccine. Integrating these new recommendations should take but a few minutes. So I should give you an advance warning that I'll be using the bulk of my time going over the schedule evaluation project that was recently completed. Although the evaluation project started as a usability test of the adult schedule, it later also included a review of the child and adolescent schedule. The ACIP assembled the first adult schedule in 2002, and it has been updated annually since then. Though frequently cited for being useful, the adult schedule has been criticized for being difficult to read due to a number of reasons. In response, in 2016, we conducted an ad hoc evaluation of the adult schedule to improve its usability by integrating principles of human factors and ergonomics. Extensive additional updates were done on the footnotes of 2017 and 2018 adult schedules to standardize and simplify the text. These efforts were presented to the ACIP in past meetings. Over the past year and a half, we conducted a formal evaluation of the 2018 adult schedule for usability. That project was completed 2 months ago. The purpose of the evaluation project was to determine how providers use the adult schedule to guide their clinical immunization practices and identify improvements to increase its usability. The plan centered around 3 activities. 1, conduct in-depth qualitative interviews with healthcare providers who reported being familiar with the adult schedule. 2, based on their feedback, redesign the adult schedule. And 3, administer a survey to providers to get their reactions and preferences on the redesigned adult schedule. I'll describe the results of each of these activities. 48 in-depth interviews were conducted with internists, family physicians, physician assistants, nurse practitioners, nurses, medical assistants, and pharmacists. They were screened for their familiarity with the adult schedule. That is, they reported using the adult schedule at least once per week. These interviews, each lasting an hour, included how they used the adult schedule as they worked through case-based patient scenarios. Among other findings, we learned that most providers who professed to being expert users of the adult schedule actually did not know how to use a schedule. Most reported using Figure 1, the table of immunization recommendations by age, and that was it. Less than majority reported using Figure 2, the immunization recommendations by medical condition and other indications. Few reported using the footnotes to help guide their immunization practice. A champion Xboxer once famously said, "Everybody has a plan until they get punched in the mouth." Well, our carefully laid plan was basically bludgeoned, since the rest of the evaluation plan was contingent on the results of this first activity. However, driven by this inspiring message from Invictus, which I cherry-picked for effect, by the English poet William Henley, we did forge ahead. I have to say that we did wince and cried out loud. Drama aside, though we had little concrete evidence to go with, we developed a prototype graphic based on our collective assumptions. We kept the adult schedule's overall format and flow to maintain what providers were used to seeing. We tried a more neutral set of colors in the schedule for effect. We reduced the overall amount of information on the cover page and compartmentalized the text for easy location. We included trade names along with generic names and standardized vaccine abbreviations for easy reference. We replaced footnotes with notes and listed them alphabetically because they were no longer numbered. Figures were replaced by tables. And lastly, the table of contraindications and precautions was removed, and the extra space was used to make the notes easier to read. Armed with the original 2018 schedules and redesigned draft schedules, we proceeded with the third activity, and that is to gather feedback on the redesigned schedules from providers. We surveyed a panel of about 250 internists and family physicians on the adult schedules, and another panel of about 250 pediatricians and family physicians on the child and adolescent schedules. They were asked about their impressions and opinions on usability. The 2018 adult schedule cover page and the redesigned cover page based on 2018 adult schedule were compared. Similar comparisons were made for the child and adolescent schedule. This is a comparison of the page on adult immunization recommendations based on medical condition and other indications. This is a slide. And this is the comparison of the first page of the original 2018 footnotes and the redesigned 2018 notes. The survey results were similar for both the adult and child and adolescent schedules. Overall, survey respondents preferred the redesigned cover page and the original color scheme, and not surprisingly, recommended that the font size be bigger. The workgroup's past chair, Dr. Laura Riley, was and remains a strong champion for immunizing pregnant women. But as you know, the graphic display for vaccines for pregnant women has a lot of white space, indicating that there are no ACIP recommendations for these vaccines. The vaccines in question on the adult schedule are recombinant zoster human papillomavirus, pneumococcal conjugate, serogroup B meningococcal, and H flu vaccines. We reviewed ACIP policy statements and package inserts for these vaccines and collaborated with subject matter experts to look for a better way to present the information on the adult schedule. Based on available information, we adopted the following display for the pregnancy column on the adult schedule and the child and adolescent schedule too. The inactivated and recombinant influenza vaccine and Tdap are represented by yellow blocks or recommended routinely. PPSV 23, Hep A, Hep B, and Men ACWY remain purple or recommended if another medical condition or indication is present. The live vaccines, MMR, varicella, and ZVL, and now LAIV, are contraindicated and represented by red blocks. In the adult schedule, we added 2 new color blocks, pink for delay vaccination until after pregnancy, and orange for precaution. Vaccine might be indicated if benefit of protection outweighs risk of adverse reaction. RZV and HPV are given the pink or delayed designation. Men B, though it has a delay component, is given an orange or precautions designation. Discussions on the use of our PCV13 in pregnancy has been taken up by the pneumococcal work group, so we kept it as no recommendation for the time being. Hib vaccines simply have no information available in pregnancy and will continue to have a no recommendation designation. I should mention that in June 2018, Dr. Kevin Alt and colleagues penned maternal immunization recommendations on behalf of ACOG, the American College of Obstetricians and Gynecologists. This is ACOG's maternal immunization summary table. If we overlap the summary table of ACOG's recommendations with the color scheme of the proposed adult immunization for pregnancy, they do align very nicely. One difference is that the footnote for pneumococcal vaccination in the ACOG's table describes that PCV13 should be deferred in pregnant women unless she is at increased risk for disease and benefits of vaccination outweigh risks. As stated in the previous slide, on the adult schedule, PCV13 remains a no recommendation in pregnancy, but a decision is pending review by the ACIP pneumococcal work group. A lot of effort went into standardizing the notes and harmonizing the notes with the child and adolescent schedule. In addition to the changes that I mentioned earlier, we shortened the title of the documents, organized and revised notes for brevity, clarity, and consistency, and shortened text as long as their meaning was not compromised. And so this is what we ended up with. First, the cover page. The cover page features a shortened title, simple instructions on how to use the schedule, a list of vaccines including trade names of vaccines, and compartmentalized supporting information for easy reference. An additional helpful reference on vaccine preventable disease case identification and outbreak response has been added. Next is Table 1, the recommended adult schedule by age. So this is the new table for recommended adult schedule by age. One major content change in the 2019 graphic is the separation of LAIV from other influenza vaccines because it's a live vaccine. Next is Table 2, the recommended adult schedule by medical condition and other indications. Table 2. First, the key for Table 2 has been updated to introduce the two new colors: pink for delay vaccination until after pregnancy if the vaccine is indicated, and orange for precaution. Vaccine might be indicated if the benefit of protection outweighs risk of adverse reaction. The key for the red contraindicated box now includes more information to separate it from the orange precaution. And the information added is, vaccine should not be administered because of risk for a serious adverse reaction. As in Table 1, LAIV has been teased away from the other influenza vaccines. As a live vaccine, LAIV is displayed as contraindicated in pregnancy, immunocompromising conditions, including HIV infection, and asplenia. LAIV has also been designated as precaution for use in end-stage kidney disease, chronic heart, lung, and liver diseases, and diabetes. As described earlier, the pregnancy column in Table 2 displays updated vaccination information. In addition to the changes in graphics, there are some content edits. Here's the first page of the notes, formerly footnotes. In this section, the following content changes have been made. Because outbreak responses pertaining to vaccination are decided and coordinated by public health authorities, and vaccination service providers are likely not making outbreak response decisions, indications for vaccinating adults in outbreak settings have been removed in the adult schedule. On this page, the use of Hep A and Hep B in outbreak responses have been deleted. I will note again that a resource on vaccine-preventable disease case identification and outbreak response has been added on the cover page under helpful information. As was voted on this morning, homelessness as an indication for Hep A has been added. Next, the new 2-dose series of cytosine phosphate guanine adjuvanted hepatitis B vaccine has been added to the adult schedule. And for HPV vaccination, transgender persons through age 26 years has been added. This is page 2 of the notes. For influenza vaccination, LAIV is added back to the adult schedule as an option. Information on when not to use LAIV has also been added. Like the removal of notes on the use of Hep A and Hep B in outbreak settings, the use of third dose of MMR in mumps outbreak, and men ACWY and men B in meningococcal outbreaks have been removed. As mentioned earlier, the use of men B in pregnancy has been updated to precaution. Vaccine might be indicated if the benefit of protection outweighs the risk of adverse reaction. And this is the third page of the notes. Lastly, the use of RZV in pregnancy has been updated to consider delaying vaccination until after pregnancy, and also the provider is informed that the use of RZV in severely immunocompromised adults is currently under review. So this concludes the updates on the 2019 adult schedule. And on behalf of the Adult Immunization Work Group and the many contributors who helped develop the updated adult schedule, thank you.
Great, thank you so much. And I just want to comment that the adult and the child work group really took into consideration comments heard at ACIP a couple of years ago and has made a huge effort with each subsequent year to improve the usability and readability of these schedules. So I think it's very much appreciated. But I do want to check and see if people have comments or questions about the adult schedule before we move on.
I just want to say thank you. It looks terrific. You did a great job.
Dr. Moore?
Yes, also thanks from me as well. This is a great improvement. I did have just one question on the zoster recommendation with the or, and I don't have an answer. I just wanted to bring it up. Because in the cases where zoster vaccine live is given, one may still choose to receive recombinant zoster vaccine at a later date. So it's not truly an either or situation. And in the notes section, at the very end, you had a comment about if you're 50 and over and you mentioned that the zoster vaccine live may be given, or that you can give RZV regardless of history of zoster vaccine live. But then there's a second statement under 60 and over where it doesn't repeat that, where it doesn't mention previous ZVL, and it sort of seems, it's a little bit confusing, just the nuance of that wording. And so I just wanted to bring that up because I thought some people may just go, if they have a patient over 60 and it says they can have one or the other, and just they don't look up at the 50 and over where it says that you can still have RZV if you have a history of ZVL. So just wanted to highlight that.
Great, thank you. Dr. Bernstein. And as Dr. Bernstein is getting up there, I just want to remind everybody that we're voting on the proposed schedules. There will continue to be some wordsmithing of things like that we do find, so we don't have to have all of that language clarified. We're just, and we'll send out final versions as well to the members.
Excellent. Thank you. Yes, the adult schedule is wonderful. And now I want to start first by congratulating Dr. Candace Robinson, who is our CDC lead on this work group, on the birth of her first child. So being the lead on this particular child and immunization schedule work group has taken on a new meaning to Candace like she never imagined. So congratulations. I also want to, I certainly would, our working group has 3 members from ACIP, besides myself, Dr. Szilagyi and Dr. Romero, and I do want to recognize Dr. Romero as well, who generously helped smooth my transition into this role as work group chair. I want to acknowledge our many liaison representatives that are listed on the left side of this slide, and our work group consultants and CDC leads are listed on the right, and they have made wonderful contributions as well. I'd also like to acknowledge all of the many wonderful CDC contributors for the child and adolescent work group who are listed on this slide. In particular, I want to mention Dr. Strikis and Friedman, who stepped in during Dr. Robinson's maternity leave, and things did not skip a beat with their leadership, which was wonderful and much appreciated. I would like to remind the committee and the audience why we present the schedule for a vote every fall. The ACIP's approval is necessary prior to publication of the schedule in January or February of the coming year. ACIP approval is necessary before our partners, the AAP, the AAFP, and ACOG, review and approve the same schedule. Also, no new policy is established by this schedule. Rather, it reflects a summary of all published ACIP recommendations. For the remainder of this presentation, Dr. Robinson will discuss the proposed edits for the 2019 child and adolescent immunization schedule. These edits are intended to incorporate ACIP recommendations and MMR publications that have occurred since October of 2017. We hope to improve the readability and the utility of the schedule into language that is easy for the provider at point of care to interpret and use. In addition to harmonization, there are proposed edits to tables 1, 2, and 3 that you will see. There are also content changes for the notes, formerly footnotes, for hepatitis A, hepatitis B, polio, influenza, MMR, meningococcal, and Tdap. This session will conclude with a discussion of the proposed edits, followed by a vote on both the adult and the child immunization schedules. I'll now ask Dr. Robinson to take the floor and walk us through the proposed edits to the child and immunization schedule.
Good afternoon. So we will go through the updates for the 2019 child and adolescent schedule. It's been updated to reflect recommendations published or voted upon regarding influenza vaccination and the use of LAIV, hepatitis A and homelessness as an indication for vaccination, hepatitis B vaccination with the use of the CPG adjuvanted Hep B vaccine, and Tdap vaccination regarding vaccination of persons who received Tdap at 7 through 10 years of age. Changes that impact multiple portions of the schedule include the adoption of the updated immunization schedule graphics demonstrated in the adult presentation, and minor edits throughout the notes section to improve harmonization between the child, adolescent, and adult immunization schedules. For the cover page, the child and adolescent schedule has adopted an updated title, as you'll see here. And you'll also notice that the color scheme for the child and adolescent schedule is purple, so that way it's readily distinguished from the adult schedule by any provider who's looking at the schedule. The table of vaccine abbreviations and trade names remains on the cover, though the appearance has been updated. A box with instructions outlining how to use the schedule has been added to the cover, and there are 4 sections for Table 1, Table 2, Table 3, and the notes. Additionally, a section with helpful information and resource links has been added, including a link for outbreak guidance. For Table 1, the routine immunization schedule, this is the new graphical presentation of Table 1. As previously noted by Dr. Kim, the footnotes will be presented unnumbered and in alphabetical order. Therefore, you'll note the superscript notes that previously directed a user to the footnotes have been removed from this table. Additionally, in all places that previously referred to a numbered footnote now simply says "See notes." Within the influenza row, LAIV has been separated from IIV. And within the hepatitis A row, a purple bar has been added for those 6 through 12 months of age to indicate the recommendation for use in infants who are traveling to an area of high or intermediate hepatitis A endemicity. And this mirrors the similar bar that we have present in the MMR row. For the Table 2, the catch-up table, the graphical appearance has been updated. In addition, the order of information in the highlighted boxes has been edited for clarity. Now the criteria under which no further doses are needed is presented first, followed by recommendations for those in whom additional doses are indicated. Within Table 3, the vaccination by medical indications table, the child and adolescent schedule has added the pink color, indicating delay vaccination until after pregnancy if vaccine indicated, and which will be used in the pregnancy column for HPV vaccine on the child schedule. The pregnancy column for 4 vaccines will remain gray. For rotavirus and DTaP will remain gray as pregnancy is not applicable to the population for which these vaccines are recommended. And Hib and pneumococcal conjugate vaccines will remain gray for reasons detailed by Dr. Kim in the previous presentation. Within the legend, descriptive text has been added next to contraindicated and precaution. And within the influenza row, LAIV has been separated from IIV. You will note that the heart disease and chronic lung disease column has been subdivided into 2 columns, a subcolumn for asthma and wheezing in those 2 to 4 years of age, and a subcolumn for heart and other lung disease to demonstrate that LAIV is contraindicated in children 2 through 4 years of age with a history of asthma or wheezing, while heart and other lung diseases are a precaution to the use of LAIV. In addition to the changes made to harmonize the language within the notes section with the adult immunization schedule, there are a few content edits. First, within the hepatitis A note, which continues on the second page. Information regarding the use of combined Hep A, Hep B vaccine in persons 18 years or older has been added. A section for international travelers has been added with recommendations for vaccination of those 6 through 11 months of age and unvaccinated persons 12 months of age or older. And finally, homelessness has been added as an indication for vaccination. Within the hepatitis B note, the word all has been added to the vaccine recommendations for the birth dose for infants born to hepatitis B surface antigen negative mothers. This was added to emphasize the recommendation for this population, and the sentence now reads, 1 dose within 24 hours of birth for all medically stable infants greater than or equal to 2,000 grams. The sentence which describes recommendations for infants born less than 2,000 grams remains unchanged. Information regarding the use of CpG antivented hepatitis B vaccine and combination hepatitis A, hepatitis B vaccine has also been added to the notes. Within the inactivated poliovirus vaccination note, a bullet has been added regarding the use of combination vaccines that contain IPV and reads 4 or more doses of IPV can be administered before the 4th birthday when a combination vaccine containing IPV is used. However, a dose is still required after the 4th birthday and at least 6 months after the previous dose. This mirrors similar language that appears in the hepatitis B footnote for use of combination vaccines that contain hepatitis B. In the influenza vaccination note, LAIV has been added where appropriate, and information regarding vaccination of persons with a history of egg allergy and information regarding when not to use LAIV has been added. Language regarding the use of MMR vaccine in the setting of a mumps outbreak and MenACWY and MenB vaccine use in the setting of meningococcal outbreaks has been removed. Finally, in the Tdap footnote, the catch-up vaccination section has been updated to indicate that those who receive a dose of Tdap at 7 through 10 years of age should receive the routine dose of Tdap at 11 to 12 years of age. And this is to be consistent with the Tdap recommendations published in April of this year. Additionally, a link to information regarding the use of Tdap and TD for wound prophylaxis has been added. Now, the graphical updates presented apply to the print version of the schedule. However, CDC is also redesigning the immunization schedule web pages. The purpose is to enhance usability for healthcare providers and the public and to ensure access to vaccine schedules and tools to determine what vaccines are needed. The improvements will also be made to schedule readability across multiple formats, including tablets and handheld devices. The redesign will make it easier for users to access other important immunization-related information, such as easy links to vaccine information statements, vaccine administration tools, and vaccine storage and handling information. We are also making some changes to the schedule-related products. The online schedule usability is being improved by allowing users to tab between schedule tables, making it easier to use the schedule in its totality online. Additionally, because adult vaccine recommendations vary by individual needs, the adult easy-to-read schedule is being removed, and instead we will promote the adult vaccine assessment tool, which provides vaccine recommendations based on individuals' conditions as needed. And the childhood assessment tools are also being streamlined, allowing us to eliminate duplicate products. So we'll open it up for discussion.
Great. Thank you so much, Dr. Robinson. I just want to see if anybody on the committee has any questions or comments. I see some outside the table. Dr. Walter?
Again, I want to thank both committees for all the work they did to make these really look a lot more user-friendly. And particularly the notes, I think they're much easier to read than they used to be. So thank you. I did have a question for Drs. Kim and Robinson about the use of the contraindication for 2 groups on the pediatric table and one group on the adult table for LAIV. And the groups would be asplenia and CSF leaks and cochlear implants. I believe the term that's used in the current flu recommendations, or what's written, is that there's really a lack of data, and it's not contraindicated, but it's not recommended. So how do we distinguish between not recommended and contraindicated? Because I always think of contraindicated as being a little bit different. And I understand that the goal to simplify things to the provider, but I think we may need just to nuance that a little bit.
Yeah, thanks. We have tried to keep it simple as possible while also, it's a broad document, but it's also very condensed. So I think we went to contraindication because it just says it not recommended, though it's not, as you noted, a labeled contraindication. But we can also explore how we can address
Do you think
that.
we should footnote that or something somewhere? I mean, I hate to add more footnotes, but to which you've simplified. But.
We can absolutely, David and I can coordinate and harmonize how we better indicate that on both schedules. And go ahead.
One simple way to look at that is perhaps to see whether the vaccine is live vaccine or not. And specifically, where you see contraindication, we refer to live vaccines as being contraindicated, whereas in other scenarios, the vaccines are actually not live vaccines, where we have not recommended text.
Dr. Mendelman.
Yeah, thanks for that point. I think Melinda Wharton, CDC, we'll take a look at that and see if there's some way to better reflect the nature of the concern rather than the contraindication language, because I agree, that really is not really what we usually mean by contraindication.
Yeah, I think we've thought about that on the flu working group quite a bit, so.
Dr. Mendelman.
Thank you. Amy Middleman from Society for Adolescent Health and Medicine. Candace, do you mind moving to the next slide, the picture of the whole?
Which slide?
The next slide. The table, first table.
Oh, okay.
It's the back.
The first table, it's actually, let me see. Give me 1 second. I think it's slide 10. I can't get it to go from here.
So in this slide, I thought, now I missed a couple of the last working group meetings, so I'm so pleased I get to announce that to everyone. But on the TDAP bar, my understanding was that because we have teenagers who become pregnant, that catch-up bar would be half green and half purple, since we do have high risk, the pregnancy being a risk category that indicates another vaccine. Did I miss something, or were we not going to split that bar, that green catch-up bar, to be half green, half purple to include those who become pregnant?
Yeah, we can split that. We'll split that bar.
Thank you.
Dr. Maldonado.
Thank you for that, the updates around especially around the infant schedule. And I had a question, though, about the outbreak section for both. And I realize that it's probably a little confusing to talk about that. But I think for some of the pediatricians, especially with the third dose of mumps, can you explain again how that information is going to be made available to the providers? Because I think sometimes they ask us at the academy, should they be contacting the public health agencies, or will the agency be contacting them, et cetera? So this is always helpful to have up front for them, especially right now with the ongoing potential outbreaks that we've been seeing in colleges. Thanks.
Yes, the intention is to have the provider refer to the public health agency in the setting of an outbreak. On the cover page, we have a section that basically says report suspected cases of reportable vaccine preventable diseases or outbreak to your health department. And we also added the link on the cover page for outbreak response information. So the thought process was that providers should not be making these decisions regarding vaccination in the setting of an outbreak independently, that we would want them to be in contact and in communication with their health department when making those vaccination decisions.
I need bigger fonts.
Let's see. There we go. I got it. There we go. It is in that report section. The first bullet says suspected cases of reportable vaccine preventable diseases. Yeah. Mm-hmm.
Dr. Bernstein?
Dr. Maldonado, would you think it would be helpful to have something under the notes as well? Is that what you're suggesting?
You know, I just feel like for the pediatrician with the already complicated schedule, if they get cases coming in, I'm not sure how often they're actually going to contact the public health department. So a reminder, maybe even another reminder for them would be helpful. But again,
Perhaps in the notes section, then you think
Yeah.
that they would more likely go to the notes section than to the
they
first?
might miss it. Yeah, I just worry about that.
So we can add for the child adolescent schedule, we have an additional information section where we can re-emphasize that information without having to add it back to each footnote. We could do that.
Dr. Moore?
Yes, thanks. I think the key is to drive folks to public health on those complex outbreak situations, but it certainly would be doable to put something, I would think, in the notes section that says, for outbreaks, refer to public health, and then the reminder link to the surveillance manual, because the surveillance publication from CDC is available online to anyone, although it's tailored to public health. Anyone who wanted more detailed information could also go there. But really, it's for outbreaks, see public health, and the nuances necessary can be described clearly there.
Okay, Dr. Artmer?
I'll just point out that I interpret that as if you have a suspected case of a reportable disease or you think there's an outbreak, you report it to the health department, not that if you're in the midst of an outbreak, here's what to do, or that you need to contact the health department to figure out whether you need to vaccinate. So having that information someplace, whether it's in the notes or wherever, would be helpful.
Great, thank you. Do we have any other comments, or would somebody like to make a motion to vote on these two recommended schedules, knowing that all of these comments will be incorporated into the final version? Dr. Atmar?
So move to accept both.
Great. Dr. Fry seconds the motion? Great. So given no further discussion, we can have public comment before the vote on these two schedules. I have a list of people who have signed up for public comment during this public comment session. If we're not totally sure that this is the right list, so if I don't call your name, please come line up at the end, but I'm going to call your names and you can line up in this order, please. Ms. Brandy Vaughn, Priscilla Zelensky, Patricia Noenschwander, Denise Jaklowski, Jamie Herring, Leanne Ducat, and Jamie Juarez. And then anybody else, please line up. And we'll have about 15 minutes for public comment. So is Ms. Vaughn ready? Please. If Ms. Vaughn isn't there, is Priscilla Zelensky ready? Great, thank you. And when you speak, just please announce your name and where you're from, please.
My name is Priscilla Zelensky, and I'm from Georgia. I'm here today because I have been in nursing for a while. I have never in my life had any knowledge, been taught any knowledge of vaccines, the side effects, the ingredients, or anything. I have took care of people. I have took them to get their vaccines. You know, I have done so much to do with the health care. My daughter, I took her in for her 4-month well check for her routine vaccines. She was given the hepatitis B, the DTaP, the Prevnar 13, and Rototec. Instantly, right after, my daughter experienced encephalitis. She screamed and screamed to the top of her lungs. She would not sleep, rest, eat, drink, nothing. She became very lethargic. I could not even see my baby through her eyes. You know, I know my child's heartbeat. You know, she had completely lost herself altogether. Instantly, my child died. Gone. Boom. Just like that. My child gave it all for the herd. And I just ask, I was told that before I even came here today that there's a lot of voting done with little or no data. I didn't believe it. I was proved totally wrong when I came in here today. And I just ask you guys to please do your research. Please. As a mother, I'm begging you. I've seen it happen over and over again. I mean, I'm helping mothers now whose children have passed away just like mine because there's no corner mandate. They don't know what to test for. Okay, I'm having to give them, stuff to take to the pathologist for certain things to test because it's not done. These children are dying. Thank you. One more thing. Hosea 4:6, my people will be destroyed from lack of knowledge. Thank you.
Thank you.
Hello. Thank you for the opportunity to speak in a public comment. My name is Patricia Neuenschwander. I'm a pediatric nurse practitioner. I've been a nurse for over 25 years. I come here today, I believe, representing numerous other medical providers and our concern about the decline of our children's health. Children are this country's most valuable resource, and they are sick. They are sicker than they have ever been previously in history with chronic disease. Members of this committee are some of the most important people in the world when it comes to vaccinations, recommendations, and vaccine safety. You influence medical providers with whatever your recommendations are. I can tell you that if you say give pregnant women a flu shot, we give pregnant women a flu shot. If you say add a third MMR, we add a third MMR. If you say change HPV from 3 doses to 2 doses, we change to 2 doses. We follow your recommendations blindly based on a faith that you have done the research and that you have looked into this on our behalf. We don't have time to do all of that. The CDC is supposed to be concerned about the prevention of all diseases, not just infectious diseases. I understand that your focus here is on vaccination, but we don't know how vaccinations may be contributing to the skyrocketing chronic disease we're seeing in our children. Those studies have not been done. And I'm sure that you're aware that HHS hired the Institute of Medicine in 2011 to look at vaccine injuries. And they asked them to look at 158 common injuries reported for varicella, hepatitis B, tetanus, MMR. The IOM located science which convincingly supported a causal relationship for 14 of these serious injuries, including pneumonia, meningitis, hepatitis, measles inclusion body encephalitis, febrile seizures, and anaphylaxis. The review found sufficient evidence to support acceptance of a causal relationship for 4 additional serious injuries and favored a rejection of a causal relationship for 5. So, for the other 135 vaccine injury pairs, over 86% that were reported in this review, the IMO found that the science simply had not been performed. We don't know. In addition, the current vaccine schedule has never been tested for safety of the entire schedule. The Institute of Medicine was asked in 2013 to evaluate the safety of the entire schedule, which is what you're here approving today. And they found that no studies have been conducted to validly assess the safety of the entire schedule or even portions of it. And that's a quote from their report. We have witnessed a rise in chronic conditions in our children, including asthma, eczema, autoimmune disease, learning disabilities, allergies, ADD, ADHD, seizures, developmental disorders, autism, and many others. And we don't have any knowledge if vaccines may be contributing to this. U.S. children are far more likely to die before their first birthday as infants in this country than in other developed areas of the world. Suicide is the second leading cause of death in our teens. Half report to have at least one mental, emotional, or behavioral disorder. 1 in 6 children have a developmental disorder, and the proportion of public school children now is 13 to 25% are receiving special services, which is what leads me to my request today. More and more parents are questioning vaccine safety and the safety of the schedule. I'm not sure how to respond to their concerns. They want studies on the vaccine schedule related to safety, but according to the Institute of Medicine, those have not been done. They want to know if vaccines are contributing to the rise of neurodevelopmental disorders, including autism, of which only one vaccine, the MMR, out of 16 has been studied as it relates to autism. It is mystifying that there is almost no outcry in the medical, public health, or government circles to find answers and solutions to improve the health and well-being of our children. In the presentations presented today, there was an enormous amount of data on the effectiveness and cost-effectiveness of vaccination, yet little on the safety, and none on long-term safety. Please consider placing some urgency on resources and priorities to evaluate the long-term safety of vaccines, the vaccine schedule, so medical providers can provide adequate published research to their patients and not just tell them they should take the vaccines because I say so. Thank you for your consideration.
Thank you very much. Next, we have Denise Drzalowski, and I would like to remind everyone to please try to keep your comments to under 3 minutes so we can hear everyone.
Thank you. My name is Denise Jaglowski, and I came here from Michigan yesterday to speak to you. I'm a retired sleep disorders technologist. I did sleep studies on infants and adults. And I just find it absolutely despicable that you're speaking about or even considering giving vaccines to pregnant women. I could just stop there because it's just unbelievable that you would even imagine that. Have you ever seen your own website page that lists the vaccine excipient and media summary where you list human and animal DNA is in our vaccines? Have you even ever read this? You know, and this is available to parents if they would even know that it's. I feel they're not even being given full informed consent to know that these lists are available, that they can ask for a vaccine package insert. And for example, the flu vaccine package inserts say, if you get this vaccine as a pregnant woman and you, well, first of all, if you get the vaccine, call and let us know because you're part of our ongoing research. Because apparently rats are too expensive, so we're going to just give it to the pregnant women, humans, directly. And this is absolutely despicable. So I can't believe that you're adding more and more burden to the brains of our children and that you expect us to be a strong nation and go forward and be intelligent when we are so compromised. Thank you.
Thank you. Jamie? Ms. Jamie Herringa?
Hi, I'm Jamie Herring. I'm from Grand Rapids, Michigan. I'm here because, excuse me, I'm getting emotional. I'm a mother, I'm a grandmother, I'm a friend, I'm an aunt, I'm a teacher, and I'm an advocate for children's health. And what is happening to our kids is so scary. I've got vaccine injured kids in my family, and it's just very, very frightening. Excuse me. I can read. So I read the independent research that's done by very brave scientists and researchers around the world, research that the CDC should be doing. It's out there. The information is there. And I can't unlearn what I have learned from all of the studying that I've been doing. Our children's, all the toxins and all the adjuvants in the vaccines, not proven safe to inject into a baby independently or as a group. And we're compromising a growing immune system. We don't know what we're doing to it. We're super boosting it unnaturally. And what are the consequences? Does anybody know? Well, there are some studies now that are showing that children that have immunizations also then die earlier from other diseases. We should know this before we inject our children with this stuff. There's too many questions to be doing this kind of a schedule. Our kids are an experiment. They're guinea pigs. And I think that's so unfair. We've traded off, these diseases for lifetime effects on kids. These families and these kids are in prison. They're in prison for the rest of their life, some of them the ones that are severely compromised. The study needs to be done, and the CDC should be doing this. They should be working with independent researchers, not shutting the door on it. You should not be treating our children like this without positive proof that this is all safe to do to our children. It's not there. I'm haunted by this. I can't even sleep at some nights sometimes because I'm so haunted as I learn what's happening to our kids because of our lack of information. And informed consent, who has that? If you're going to have informed consent, you've got to have the package insert, you've got to have the ingredient label, you've got to have your doctor talk to you about there. It doesn't happen. It didn't happen for my grandkids. That doesn't happen. Doctors have to be informed. They're not. They're told to do this, and that's it. We need a better program for our kids. How are we going to continue to educate these kids? In fact, my thing is, we cannot improve education. I don't care how much money you put into education. You can't improve it unless you improve the health of our children. You can't improve if we've got sick kids that can't learn. How are we going to pay for this? Who's going to take care of these kids? Where are we heading with this? So I'm just asking you to take this seriously, and let's get down and work with people that have done some of the research independently and not just shut the door on them and figure this out for the safety and the health of our children. Please.
Thank you. Thank you. Next, we have Leanne Ducat.
Hi, thank you for having me. I'm a little nervous, so bear with me. My speech is actually starting off with a quote from Dr. Paul Offit, who, thank you very much for joining us for lunch. We really appreciate it. It's very kind of you. To quote Dr. Paul Offit, you can never really say that MMR doesn't cause autism, but frankly, when you get in front of the media, you better get used to saying it, because otherwise people hear a door being left open when there shouldn't be a door left open. Well, the door's been busted open. How? Because we discovered that recently we discovered that in reality, only one vaccine and one vaccine ingredient have ever actually been evaluated for a relationship to autism. When the remaining 37 common ingredients and 15 vaccines have been blatantly ignored, you cannot definitively say that vaccines don't cause autism or any other chronic condition that 1 in 5 of our children is currently diagnosed with. I always tell my 9-year-old about integrity, that it means doing the right thing whether someone's looking or not. Well, we're looking. We're all looking. We're looking at why this committee is relying on safety studies that use adjuvants or other vaccines as placebos to downplay adverse events between 2 control groups. We're looking at why we're giving babies vaccines for STDs on their first day of life, when mom is not infected, preventing any type of baseline analysis to watch for future neurologic progression. We're looking at why we're vaccinating pregnant women when manufacturers admit no safety evaluations have been conducted on pregnant women or even humans that tiny. We're looking at why vaccines are given to fragile populations like the newborn and elderly when the recommendations are based on incomplete studies funded by the very manufacturers who are immune to liability. We're looking at why the recommendations of this committee only seem to make sense from the perspective of profitability for the pharmaceutical companies and not at all in the interest of public health. We're looking at why this committee is actively dismissing a tsunami of parents and professionals from every racial and socioeconomic demographic, vehemently calling for answers, accountability, and immediate change. We're looking at the stark conflicts of interest that riddle this committee and all of its influencing cohorts, including how Robert F. Kennedy Jr. is demanding that the Office of the Inspector General investigate fraud and obstruction of justice committed during the Autism Omnibus hearing of 2009, leading to the denial of over 5,000 injury compensation claims. We're looking at all sorts of things, but mostly we're looking, planning, and organizing what we're going to do about it. And we'll see you back in February. Thank you so much for your time.
Thank you. I would like to remind people to please, at this time, comment specifically on the schedules on which we're voting. The next person is Jamie Juarez.
Hello, thank you for having me. I'm going to read this time. So I'm Jamie Lynn Juarez, and I'm a mother of 4 amazing children. One is severely injured from vaccines from the particular schedule on agenda items. And he's diagnosed with severe autism, but we all know this is really viral encephalopathy. That's why mothers like me and all of us activists together call it the big lie. He also has seizures. I have 2 unvaccinated children. They're straight A students. They're voted number 1 in their division for soccer. And I have another daughter that's mildly injured, recovered, and had a full academic scholarship to University of Laverne. Like many of you on the committee and those in the room, I'm also educated. I did a PhD, my doctorate in education at USC, where I'm currently a candidate. We have accumulated data on thousands of victimized children by vaccine injury, school districts, and social service fraud and child abuse negligence. I'm also a licensed marriage and family therapist. I'm a behavior analyst, credentialed school counselor in the state of California, where I've testified in thousands of hearings for thousands of patients, legitimizing that we're dealing with public corruption. I'm proudly the president of Hope Inc. Academy, where I've also testified in over $30 million in settlements in a legal system that hides the truth by forced settlement agreements, committing fraud and federal crimes of colored law abuse. If you would like to learn more about me, because I know this is about the agenda item, I am a #1 best-selling author of Hope for Autism. So when it comes to this schedule, I think it's really important that we do listen to RFK Jr. and his recently petition to the Office of Inspector General at the Department of Justice and both congressional judiciary committees to investigate the alleged fraud and obstruction of justice of the two key DOJ lawyers' actions in the 2009 Vaccine Court Omnibus Autism proceedings. My son is one of those 5,000 children who's been continuously subject to issues like this schedule and not doing the real data analysis that we need. The complaint by RFK Jr. has now been transferred to the Department of Justice Office, Professional Responsibility, and we urge everybody here in this room and online to do the same. As you know, in the section of 1928 of the Social Security Act that was established, you are to periodically review as appropriate, revise this list for vaccine administration to children and adolescents eligible to receive vaccines through the vaccine program. But this hasn't been done. What you guys are doing is not being done accurately according to the standards of research. In particular, we're not looking at MTHFR, mitochondrial dysfunction, GI issues, immunological sensitivities, which are growing indescribably. Parents are having their informed consent protection under the law violated. There's no pre and post studies with independent variables researched against the enormous amounts of viruses, toxins, bacteria in combination. And thank you, Dr. Offit, for having lunch and those discussions with us, for agreeing that perhaps there's some adjunctives in these vaccines that are causing some of the epidemics we're looking at. We can pre-screen, we can do retrospective and prospective studies with control groups, and the data is available. We have the data, ask us for it. There are highly credible doctors and researchers that don't have bias, that are independent of the pharmaceutical companies that are controlling what's happening in our country. I do want to thank President Trump and his administration for his diligence and his assurance that he'll be looking into these things. And lastly, I just want to remind you, hopefully I'm okay on time, I'm not sure, of the World Health Organization Code of Conducts, because we have to be looking at the funding of these studies, the data analysis that you're all doing from Pfizer and Merck and all these companies that are funding for the billions of dollars. We have to recommend products that are free of any harm and hold them accountable for liability, and we currently don't have that, as well as we're ignoring whistleblowers in many different arenas. So having said that, I thank you all. I do believe maybe one, maybe two, hopefully all at some point will do the right thing and really take a look at what's happening to our country. Thank you.
Thank you. Jamie Juarez, please. I'm sorry. Okay. Jocelyn Gallion.
Hi, hello, my name is Jacqueline Gallion. I'm on the board of Informed Choice Washington, and I represent thousands of parents and citizens across the state of Washington who are done following or trusting anything from this committee. You recently recommended 2 vaccines with new adjuvants that were never safety tested with other adjuvanted vaccines, admitting that in the real world, they would likely be administered with other vaccines, and you had no idea what sort of reaction that would cause. After your unanimous vote, you discussed safety signals that had appeared in clinical trials, and you said you would be watching post-market reportings for reactions. That post-market surveillance is us, the public, and we did not agree to participate in safety trials. No warnings are being given to the people receiving these new vaccines. You simply handed the American public over to the pharmaceutical company like dispensable guinea pigs. These are just two recent examples of how you are putting our lives and our children's lives in jeopardy. It is well known that someone with mitochondrial impairment is more likely to have a vaccine adverse reaction that gets out of control and ends up causing severe injury, even autism. Former CDC Director Julie Gerberding admitted this on TV. And so did Dr. Kelly and Dr. Zimmerman from Johns Hopkins recently under oath. Children with mitochondrial impairment are at risk of vaccine injury, leading to autism and other chronic disease. Does the ACIP work to ensure nobody with mitochondrial dysfunction is vaccinated? Does the ACIP recommend screening? No. You do the opposite. You say children can be vaccinated while on antibiotics, and you ignore studies that show antibiotics are one of the many drugs that are toxic to mitochondria. You ignore studies that show acetaminophen is toxic to mitochondria, and you do not warn pediatricians and parents to avoid it around the time of vaccination. Instead, when vaccination reactions occur, families are gaslighted, and they do not receive proper care to heal the vaccine injury. Aluminum is known to be toxic to mitochondria, but you allow multiple doses of vaccines with aluminum to be administered throughout infancy. And by the time they reach their 12-month or 18-month visit, the aluminum has done its damage. And the next round of vaccines sends them into a serious reaction. So I'm here today to say no. We are done. We are done with your recommendations, done with your guidelines, done with you selling us and our children to pharmaceutical companies. And before you vote on the immunization schedule recommendation changes, these concerns need to be taken into account. And know this, we will not be your test subjects. It is time the American people call for the separation of pharma and state. I'll leave you with a quote by Dr. Stanley Plotkin. Science never completely understands anything. Thank you.
Thank you. Ms. Denise Aguilar.
Hi, my name is Denise and I'm from California, where it is now mandated for our children to be vaccinated in order to go to school. The amount of homeschooled children in California has skyrocketed, which says a lot. And I'm really hoping the people who are on their telephones look at the parents that have traveled thousands, hundreds of miles at their own expense to come and speak to you guys. So the best thing you guys can do is to give us a little bit of respect and look at us. We have a problem on our hands, and adding more vaccines to the schedule is not a solution. I had to pick my daughter up. She almost killed herself from the HPV vaccine. And here you guys sit, putting more vaccines on the schedule.
Thank you so much. Ms. Brandy-Vaughn.
Hi, everybody. It's my first time at the CDC, but I'm sure some of you know me very well. I used to work for Merck, and now I speak out against the dangers that the pharmaceutical companies don't tell you about pharmaceutical drugs and vaccines. So when I was trained at Merck, which was a very intense training, we were told that all drugs go through a gold standard process, which is a double-blind, placebo-based, long-term studies. Well, for vaccines, as most of you know in here, they don't have to go through that process because they're categorized differently. So what's happening is we're seeing a lot of these vaccines being put onto the market, and our children are test subjects. And right now we're seeing almost half of all children with a chronic illness. And if you look at the studies, the independent studies that are not funded by the pharmaceutical companies that have filled this room, and you will see over 1,000 studies, more than 1,000 studies, showing the harm of the vaccines that are released onto the market without proper testing. So I ask that when you're considering the immunization schedules today, that you really take a step back, because our children and adults, in the U.S., we've never been sicker. Our health is suffering. And I have done a lot of research on the difference between injection and ingestion. Now, this is something the pharmaceutical companies will never tell you. But anything injected goes straight into the circulation. It goes to vital organs. There's a great study on aluminum, which shows that 95+% is absorbed in the body tissues. When you eat something, when you drink something, when you inhale something, 95% of that is filtered out through our body's natural detox processes. So anything you inject is going to be far, far more dangerous and far more potent. So what's happening now is because the pharmaceutical industry, it's a saturated drug market, and it's expensive. There's liability, which unfortunately there's no liability for vaccine makers with vaccines. So you're seeing all of these new vaccines in development, almost 300. Because if they can call it a vaccine, they can A, inject the body with toxins and make them far more potent and create further health issues that sell the drugs that make them, the most powerful industry in the world. And we're seeing them without liability. So they go through the committee here. And I sat this morning and I was disturbed. And I've watched this on the television, on the live stream before, but I was really disturbed. Doctors asking about safety signals and when safety information is going to be available. And the answer is always like, 5 sentences that distract with no real answers. Well, enough people have to be hurt by the vaccine before we'll know if it's safe. Enough people have to die from the vaccine before we'll know it's safe. It's not acceptable because the American population pays really good tax dollars to make sure that this committee is not biased and to make sure that this committee is putting the people of America before the profits of the pharmaceutical industry. And I saw it firsthand when I sold Vioxx for Merck, that these agencies, including the CDC and the FDA, are not doing their job anymore. And so I ask you today, when you consider these recommendations, consider all of the children and the adults and all the pregnant women that are going to suffer because of your vote. Because there may be a lot of money backing these recommendations from the pharmaceutical industry, but you are beholden to the American people. Please don't forget your mission. Thank you.
Thank you all. I believe that is the end of the public comment period prior to the vote. So the vote is to approve the adult and child adolescent immunization schedules. We will take an electronic vote. Can you tell me, is the voting open? Okay, so the voting is open and hopefully be successful. So we received all of the votes, and the adult and child adolescent immunization schedules were approved with 11 yeses. We will go around the room and just confirm those votes. We'll start actually here with Dr. Romero, please.
Yes.
Lee, yes.
Szilagyi, yes.
Moore, yes.
Stevens, yes.
Zanolo, yes.
Bernstein, yes.
Atmar, yes.
Fry, yes.
Hunter, yes.
Walter, yes.
Great, thank you. So the motion passed, and I should have said this before the voting took place, but I want to remind everyone that there were no conflicts declared regarding this vote at all prior to at the beginning of the meeting. So at this time, we can take a break.